The broadcast is now starting. All attendees are in listen-only mode.
Well, greetings, everyone, and welcome to the 178th edition of the RX Question Lab. I'm Jeff Downing, Senior Director of Product at ScholarRx, and very pleased to welcome you to a session where we're going to be diving deep into the respiratory system. For step one, although if you are prepping for step two, there may be some good things that you can revisit tonight. We'll be able to challenge your clinical reasoning and help you master some of the high yield concepts connected to the respiratory system. As always, I am joined by Dr. Abraham Titus. Abraham, would you mind introducing yourself to the crowd?
Thank you, Jeff. Hi, everyone. My name is Abraham Titus. I'm an Oncology Fellow at the University of South Alabama. I've been a tutor for quite a few years now and helped help achieve their goals on step one, step two, and even on step three. So we have some great questions gathered here today. So hopefully hit some high yield topics in respiratory, and hope you walk away with something today.
Okay, so for those of you who are new, when I open this up, you might be looking at this going, Jeff, something seems off. By design, we cover up the answer choices first. The reason we do that is, A, we really want you to focus, and B, we don't want you to get distracted by a distractor, one of the answer choices, especially if it's something that you have struggled with, that maybe you don't know, something that looks, completely foreign to you for some reason. So we say, first thing, cover up those answer choices. And then, secondly, we want you to read the lead in. And within step one, when we say the lead in, that's the actual question. Okay, so that in this case, the lead in is, which of the following is this patient's most likely diagnosis? This has, been our technique from the beginning, and largely, it used to be there were some questions on step one where you didn't even need to read the vignette. You didn't need to read that scenario above it. Sometimes you could actually answer the question just by, seeing the question there and seeing the answer choices. That's highly unlikely. It's very rare for you to run into that on test day. But by reading the lead-in first, now you can kind of calibrate your focus here. You can understand, well, what am I looking for? What is the outcome going to be for this particular question? And in this case, you're probably the one of the most common question types that you're going to see on step one, which of the following is the patient's most likely diagnosis. So we're just, it's a very kind of, you can see kind of a straightforward one-step question. But again, having that already in mind allows you to get into the vignette with a clearer sense of purpose. So let's go ahead and read the vignette. A 67-year-old man comes to the office because of a 4-month history of worsening, non-productive cough and exertional shortness of breath. He is a retired construction worker and has smoked 2 packs of cigarettes daily for 20 years. Chest X-ray shows multiple small rounded opacities, approximately 5 millimeter nodules, mostly in the upper lobes, calcification of hilar nodes, and central calcifications. The pulmonary function test results are shown in the graph. You can see that there. So again, the question, which of the following is this patient's most likely diagnosis? Think about that. Perhaps you can form your own hypothesis based on what you have here as I turn it over to Abraham.
All right. So Jeff did mention a lot of high yield information on how you break down the question, things you want to focus on. We have a vignette here. We do have a chart as well, which is important to look at. And just being able to understand what you're looking for before you read into the vignette is very helpful. So let's go through, let's highlight, let's focus on lead in, let's focus on the key piece of information that this question gives us. So again, most likely diagnosis. So you're thinking about, okay, what's going on that's causing this patient to present how they are? We know a 67-year-old male with 4-month history of worsening non-productive cough. Okay, so it's worsening, it's kind of 4 months is a long time, so it's a chronic situation that's going on. He's a retired construction worker. Usually when they give you an occupation, you want to take that into account. They don't give you information like that without it being kind of relevant. He's also a smoker, so that's not highlighted, but it's important to know. A 2-pack a day for 20 years. That's a pretty significant 40-pack year smoking history. And then you see this X-ray. Okay, we love X-rays, right? So small round opacities, and mostly in the upper lobe, and then there's calcification of the hilar node as well. So they give you a lot of information, a few buzzwords that should make you start thinking about it, and they gave you a PFT. Okay, that's what this graph is. So it's a volume to time graph. We look at 2. You have the ones in the white boxes, which are the predicted for the patient's age, and then the black is the actual patients. As you can see, the flow here seems reduced in a set. And what am I looking at here? Which time points matter that you're going to have to kind of think about as you go forward. So let's get our differentials built in, at least based on this image. I should be able to say, hey, is this one or the other, which I'm going to talk about. And then based on the clinical picture and the X-ray, you kind of get to the final answer. All right, so let's look at the options here. Let's try to figure out what's going on. Let's go one by one. I like to start with E and make my way up to A, make sure I read all my options, make sure I'm not just jumping to the answer as soon as I think I say something. So option choice E, silicosis. Option choice D, mesothelioma. Option choice C, chronic obstructive pulmonary disease. Option choice B, berylliosis. Option choice A, asbestosis. Now, there are some clues here. There are some things that point away from some of these options. And there's some that are pointing towards the option, but really only one would fit this situation perfectly. It's a classic presentation, and this is going to be one of our typical pulmonology questions you want to feel very comfortable with. I want you guys to take a second, go through the question again if you need to, as we put up the options very shortly.
Okay, everybody, what I'm going to do is I'm going to launch the poll, and you can let us know, what do you think the most likely diagnosis is for this 67-year-old man? About 2/5 of you went with silicosis, answer choice E. About a quarter of you went with asbestosis. Then about a fifth of you went with mesothelioma. And then we've got some went with COPD and berylliosis, and kind of very choices here, right? So very good. So let's go ahead and hide the results, and we're going to reveal the answer. And the answer is answer choice E, silicosis. So well done, everybody. That's a good way to start the evening. It's not an easy question necessarily, and so especially if you didn't get that one right, that's okay. The key thing about Question Lab is that we want you to walk away understanding the answers for all of these, including all of the incorrect answers. So I'm going to let Abraham walk us through this one.
Great job, guys. And just like Jeff mentioned, even if you got this right, you can still learn something from this question. So it's all about understanding the concepts. This question can be worded a little differently, and one of the other options could have easily been the correct answer. So let's work our way through the story. Let's try to figure out what's going on and what this graph means, right? So that's the first thing that kind of attracts my eye when I look at this question. Look at this graph. Even if I don't fully analyze it, I just understand there is less flow or less volume going on in this situation, right? So the normal patient has 5 liters at 0 seconds, whereas this patient has about 3.5 liters. So that's already a reduced volume. So your total lung capacity is going down. That's kind of what they're indicating at that point. And then as the patient blows out, you're looking how much goes in 1 second. You look at all these kind of different time points, and you figure out, okay, there's a reduction in total lung volume in the situation. So just from this picture, I can tell this patient has a restrictive lung disease as opposed to an obstructive lung disease. So that already rules out option choice C for me, right? So C, I'm thinking chronic obstructive pulmonary disease. So that's my emphysema, that's my chronic bronchitis. Those are ruled out as soon as I see that the volume is reduced. What about the others? Well, A, asbestosis, B, borreliosis, and E, silicosis are all technically restrictive lung disease. And mesothelioma is kind of its own unique thing. You're thinking about, this is a type of cancer of the pleura. It can lead to some restrictive symptoms, but typically they're going to have to give you a very clear presentation of, recurrent pleural effusions, a mass present in the pleural area, and then most commonly they kind of give you a history of something like asbestos exposure. So, retired construction worker, there's a possibility that they got exposed to asbestos, but it wouldn't present with some of the X-ray findings that the patient has. So let's go through the X-ray findings and let's see what they're really trying to get at here. So construction worker is important. They're being very vague about it. They're not saying sandblaster. They're not saying, quarry worker. Those are the classic silicosis that we kind of look for. But construction worker, they're playing it broad because they want you to use more than just occupation to figure out what's going on. Right? Same with asbestos, right? Asbestos, we use the shipyard all the time. That's the one that they always say, look for shipyard, think asbestos. But they don't always give you that. And then borreliosis, typically they're going to go with something in the, aerospace engineering field, because that's kind of really where you would expose to beryllium. So silicosis in the situation, it's a chronic dry cough. And they have these findings on their X-ray, right? These are called eggshell calcifications. You may have heard these go, and you never really understood what they are. So eggshell calcifications are just these lymph nodes in the hilum. So hilar lymph nodes, which is the middle of the chest, that gets calcified, and they look like little eggshells on the chest X-ray. So we call it eggshell calcifications. That, with the presentation of, this guy's a worker, he has restrictive pattern, really points towards silicosis. And the other big clue is always pay attention to which lobe we're dealing with. Think about upper lobe is silicosis, whereas lower lobe is asbestosis. So that's kind of a little trick that I also remember. And I think it's in first aid as well. It kind of talks about, asbestos is something we see in the roof that does, insulation in the roof. So think opposite. So if it's in the roof, it's in the bottom lobes. Whereas silica is found in the ground, in rocks, that's in the upper lobes. So opposite of ground is up and opposite of roof is down. So that's how I always differentiate. And those are the two that they always want you to separate: asbestosis from silicosis. Borreliosis, they're really not it's always a distractor unless they're going to talk about aerospace stuff. Don't really fall for that. COPD would not be in the situation, and mesothelioma would not fit the situation as well. So good job if you guys got this right. If you didn't, hope you learned something, and we can kind of take away from this. And really, as you level the questions up, you really need this base level understanding of these diagnoses.
Okay. Yep. Great job. We are off to a good start, and hopefully some good high yield points that you were able to take away there, especially with the differences and where you'll find asbestosis and silicosis. Good stuff. Good stuff. So let's go ahead and move to question 2. And once again, we have an image to help us out. So we've got the answer choices covered up, and we're going to start by reading the question. Further workup for this patient would most likely show which of the following abnormalities. Okay, so that's good. You may be looking at the X-ray here, and maybe you're already seeing something. So again, by reading that lead in first, you get an idea of what it is, what kind of info you're trying to collect and parse. So with that, let's go ahead and read the vignette. A 35-year-old man comes to the clinic because of shortness of breath, which has gotten progressively worse over the past several years. The patient has no history of smoking. Physical examination demonstrates expiratory wheezing bilaterally and increased work of breathing. Serial pulmonary function tests reveal gradually increasing total lung capacity and residual volume. X-ray of the chest is shown. So again, the question, further workup for this patient would most likely show which of the following abnormalities. think in your head what what possible abnormality you might you might expect with this type of patient as I turn it over to Abraham.
All right. So a different style of question. It's not just asking you about what's the diagnosis based on the situation, but it's asking about the labs, right? And this is a little bit of a different pace of question. And instead of giving you a volume PFT, they're giving you an X-ray. They're not even describing it; they're just kind of giving it to you, and they kind of give you some explanation and a history to go off of. So let's go through, let's highlight some keywords here. Let's figure out what we're dealing with, and let's try to get to an answer. Okay, so here we got the same thing. Remember, the lead-in is always important. Which of the following laboratory abnormalities would we expect? So, right, workup will show which of the following abnormalities in this patient. We have a 35-year-old man, came in with shortness of breath, that's progressively getting worse. Okay, that's important to know. No history of smoking, that's pretty interesting. Demonstrates wheezing bilaterally and increased workup breathing. Okay, gradually increasing total lung capacity and residual volume. So they're doing serial PFTs, pulmonary function tests. They're doing these, they're checking them, and they're noticing that over time, his total lung capacity increases and his residual volume also increases. And they give us an X-ray. It's kind of even if you don't catch something right away, try to make it fit, right? So with X-rays, they're not expecting us to be radiologists and catch like every little detail right away, especially for step one. But using the clinical picture, use that as a guide to see, okay, does this X-ray confirm what I'm already thinking? That's the best way to use X-rays in step one. So kind of understand the clinical situation, what's going on. And I'm going to talk about this in more detail when we get the answers. But how am I going to tie that to the X-ray and use the X-ray to confirm, okay, this is what is going on? Let's look at the options. Let's figure out what's going on and take it from there. So again, we've got a bunch of labs, a bunch of testings that could explain what's going on, but we don't really know why. So let's start with option E. It's elevated alanine aminotransferase and aspartate aminotransferase. So the ALT and AST is elevated. Option choice B, decreased functional residual capacity. So it's FRC. What is FRC? Option choice C, BAL or bronchoalveolar lavage fluid positive for silver stain. What would that indicate? Option choice B, blood pH of 7.33 and a bicarbonate of 18. Okay, think of acid base. What does that indicate? And option choice A, anti-neutrophilic cytoplasmic autoantibodies. Those are my ANCA antibodies. So positive ANCA antibody. So you got a wide spectrum, right? So everything from autoimmune to acid base to bronchoalveolar lavage to functional capacity to liver functions. So there's a story that's being built here based on the clinical picture. And I want you to take that with the X-ray and try to figure out exactly what we're dealing with here. Okay, so take your time, see the nuances of the question. Don't get thrown off by the options. Remember, that's why we said try to build a story in your mind before you look at the options, because the options can get tricky. There's a lot of different options. You can go many different ways. I want you to kind of think of what's going on just based on the story first, and then try to match up with the options.
Okay, so what we're going to do is we're going to launch the poll. I'm going to give you just a few more seconds. When I launch the poll, it's off a few of the answer choices. You can see that these are not your average step one answer choices. These are kind of long, so exceeded our character count on a few of them. So take a good look here, kind of try to lock it in your head, or maybe lock in your top two choices, and then I'm going to go ahead and launch the poll. So you can see the aspartate aminotransferase was cut off there at the end. Okay, we do always encourage you to never leave a question unanswered on test day. You're not going to get penalized for it, especially if you're trying to decide between two options. At some point, you just have to have a coin flip in your head, or your default answer choice, so you can select and move on. Okay, so I'm going to share the results. Let's see, where are we? This is an interesting spread. So we have a tie between decrease in functional residual capacity and elevated alanine aminotransferase and aspartate aminotransferase. And then it's very unique. I'm not quite sure if I've seen this before, where a tie for first and I guess a tie for third, with 10% of you going with anti-neutrophil cytoplasmic autoantibodies and pH of 7.33 and a bicarbonate level of 18. But quite a few went with answer choice C. So a lot of plausible options here, at least in the minds of tonight's crowd. So I'm going to go ahead and hide the results. And let's go ahead and reveal the answer. And the answer is indeed answer choice E, elevated alanine aminotransferase and aspartate aminotransferase. So tie there when we'll, tie goes to the audience. Good job. This is a tough one. So I think the key thing is we need to break this one down and make sure that we fully understand. And so Abraham's going to help us through it.
All right. Yeah, that was a very unique split. I think you guys were able to kind of figure out what's going on, but also I think this is a tough question. I think that for a second question especially, it is one that the options really throw you off. And I think that's where it goes back to the importance of understanding what's going on before you get to the options. Okay, so let's break down what this question is asking, and I want to kind of let you guys get to that. So I see a lot of people dropping the diagnosis in the question box. This is indeed alpha-1 antitrypsin deficiency. How do I know that? Well, you got a young guy, 35, relatively young. COPD is a disease of old people. I want you to remember that. So it's like it should be someone who's been smoking for many years, or someone who's like lived a lot of years, and that's going to be the people that get COPD. The 35-year-old gets something that's concerning for COPD. For example, what would concern for obstructive pattern of this? Well, you have a gradually increasing total lung capacity and residual volume. And I'm going to look at the X-ray. Look how big the lungs are. Look how many rib spots they take up here. So this is the entire chest, right? If I look at a regular, you should practice looking at normal X-ray so you can kind of see, hey, this just looks off. The lungs look like giant bags instead of normal sized. It shouldn't take up this much of the patient's chest. So you have big hyperinflated lungs. Look how dark those lungs are. So you have big hyperinflated lungs. You have expiratory wheezes and progressively increasing total lung capacity with the residual volume. This is a classic presentation of an alpha-1 antitrypsin deficiency. What is alpha-1 antitrypsin deficiency? You guys might not have reviewed that for a while. The idea is alpha-1 antitrypsin deficiency leads to our body not being able to break down the elastase in our body, essentially. So alpha-1 antitrypsin is kind of a protein that's present that keeps elastase in check. Okay, so elastase likes to break down elasticity in our lungs and cause our lungs to be over compliant, and leads to hyperinflation of lungs. So therefore, you end up having what's called pan-acinar emphysema. So there's emphysema you get in the entire lung, right? The smokers get centri-acinar emphysema, which is typically located in the upper lobes of the lungs. When I have alpha-1 antitrypsin deficiency, I can get pan-acinar emphysema. So that's the general picture. How does that relate to the answer? Where does the patient getting COPD at a young age due to alpha-1 antitrypsin deficiency lead to option E being the correct answer with elevated ALT and AST? Well, we know that elastase or alpha-1 antitrypsin is originally made in the liver. And the problem with alpha-1 antitrypsin deficiency is that it gets stuck in the liver. Instead of it going to the lung where we want it to work, it gets stuck in the liver, then leads to damage to hepatocytes, and eventually leads to cirrhosis. So the combination of early COPD with cirrhosis is alpha-1 antitrypsin deficiency. You get that pan-acinar emphysema, you get that increased lung compliance and hyperinflated lungs in someone who barely smokes or does not smoke. In the situation, no history of smoking in a 35-year-old. You should never expect emphysema in the situation. So that means something's wrong. There's something that's connecting that should explain this to me. So based on the story, I can already tell you this is a alpha-1 antitrypsin deficiency. I look at the options. I don't get confused by the ANCA and all these things. Oh, elevated AST, ALT. I know that the liver also gets affected when I mess with alpha-1 antitrypsin deficiency. Let's look at the other options here. Now, these ones, a lot of you guys got stuck on some of the other ones here. So decreased FRC, functional residual capacity. So what is that? So functional residual capacity is the combination. So when I hear capacity, it's a combination of my residual volume with regular breathing. So it's a combination of regular, it's your tidal volume plus, your residual volume in the lung. So it's functional residual capacity. This is going down in restrictive lung disease, not obstructive. In obstructive, they already tell you, oh, his residual volume has gone up, and functional residual capacity is made up of the residual volume. So they kind of rule that out in the last sentence of the question to begin with. Option choice C, BAL positive for silver stain. You're thinking more of things like aspergillosis, right? That can lead to positive silver stain. Less likely in this situation. It's not an infection. CMV can also positive silver stain. What's going on here? You'll have like hemoptysis in those situations. You'll have more of an infection picture. In this picture, there's really no fever, no signs of infection. It just looks like progressively worsening lung finding. So it wouldn't fit that. Option choice B. Okay, whenever I throw acid base in there, a lot of people do get messed up as well. Is this acidosis? What is this? So this is, you have a low bicarb with a low pH. That's metabolic acidosis, right? If I have COPD, I expect respiratory acidosis. So that would be a high bicarb, low pH. In this situation, this is a metabolic acidosis, not what's going on here. So not what I would expect in someone who's developing a emphysema picture. Then option choice A, my ANCA, whole different topic. We're going into the vasculitises. So that's if I have hemoptysis, hematuria, that's thinking my GPA, granulomatosis with polyangiitis comes into the picture. It's anything, you got to have more kidney stuff involvement if I'm going to reach for the ANCAs. Those are very less likely in this situation. You have an emphysema picture with a young person, non-smoker, you're going to go alpha antitrypsin deficiency. Stick with what's high yield, what's always tested. Great job, guys.
Okay, nice work. Again, a complicated question, and and I asked, or we passed it on to Abraham. What kind of abnormalities might you expect, and would have been very, very challenging, I think, for you guys to be thinking about that. But it is important for you to at least move your mind in that direction, because there may be things that you're spotting, whether it's within the within the history, or within the X-ray, that gets your mind moving in the right direction, even if you weren't getting to the very specific details that you saw in this one. So anyway, great job, everybody. We are halfway through tonight, so it's a good time for a stretch break, and got like I said, a raffle and a special offer. Everything that you're seeing tonight, these are all questions that come from our QMAX question bank, and that has over 5,000 questions in it. Fun thing is, I don't know if we've got osteopathic students here tonight. I'm sure we've got a few, but we've quietly added OMM questions into QMAX. So I think by the time we're done, we'll have about 180 of those complex type questions in there for level 1. And I believe tomorrow, as a matter of fact, we're going to be releasing our first self-assessment exam for step 2. So for those of you who are prepping for step 2, or prepping for both step 1 and step 2, that'll be our first SAE for step 2 CK. So about that. So just among the things that we're continuing to build and add to our USMLE-Rx system. So if you haven't checked it out, I know we've got quite a few subscribers here and users new to USMLE-Rx. We do have a free trial, which you can check out at USMLE-Rx.com. You'll get 5 days of free access to everything on the system except the self-assessment exams. The self-assessment exams are only available for subscribers. Okay, so with that, I am going to off into the second half of tonight's session with question 3. Again, we've got all of the answer choices covered up. This one, we don't have any charts or radiographs, a little more straightforward. So let's dig into it. The lead-in. Which of the following is the most likely explanation for this patient's symptoms? Okay, again, kind of a classic step one type question. So with that and knowing type that we might be looking for, let's read the vignette. A 25-year-old woman comes to the emergency department because of bouts of non-productive cough and shortness of breath for the past 4 days. She has had multiple episodes of similar symptoms over the past 6 months. She has smoked 1 pack of cigarettes per day for the past 2 years. On examination, there are intercostal retractions, nasal flaring, and end expiratory wheezing heard bilaterally. So again, which of the following is the most likely explanation for this patient's symptoms? You might want to come up with your own hypothesis based on what you've seen, or maybe a diagnosis, as I pass it over to Abraham.
All right. So different style of question, definitely a little shorter, but these ones can be some of the more challenging ones because they don't give you as much information to work with. But let's break it down. Let's figure out what's going on. Let's get the highlighted words out here and let's try to understand, in this young woman, what's going on. So let's put the highlights up. Let's look at the lead in here again. Most likely explanation for the symptoms. Okay, so this may be a diagnosis question. It may be kind of more of an explanation, like the pathophysiology behind it. So we don't know yet. So let's go through the question here. That 25-year-old woman, so young woman, shouldn't be otherwise relatively healthy. Bouts of non-productive cough and shortness of breath for the past 4 days. Okay, so could be infection, maybe something else going on. We don't know what's going on. Has had multiple episodes. Okay, over the past 6 months. So it's not just a one-time deal. 1 pack of cigarettes per day for the past 2 years. Okay, so, sure, 2-pack years of smoking history. So, and has intercostal retractions, nasal flaring, and expiratory wheezing heard bilaterally. Okay, so physical exam is always important in pulmonology. You want to understand what they mean when they say things like, expiratory wheezing or inspiratory wheezing. You want to know the difference between nasal flaring, intercostal retractions, and kind of just how they generally present. Should have a differential already in your mind just based on the clinical picture here and using your clinical judgment. But if not, try to look at the options, maybe use that to kind of work backwards if you need that. But in this question, the picture they're painting here really points towards one particular diagnosis. Okay, let's look at the options here. Let's figure out what they really are trying to get us to think about. Put the options up here. All right, so this isn't a diagnosis question, right? So they expect you to get the diagnosis without even looking at the options. You need to know the diagnosis based on the story and use the pathophysiology to pick the correct answer. So we got some words that describe what's going on in multiple ways. And this is a classic for step one, right? Knowing kind of on a cellular or kind of a science level, what's happening and what is the cause of this condition. Let's break it down. Let's go through the options here before we make a decision. Option choice E, reversible airway obstruction secondary to bronchial reactivity. D, reduced ciliary clearance by the respiratory epithelium. Option choice C, intrinsic mutation of the chloride channels in the cell membrane. Option choice B, inflamed bronchi with neutrophils. Option choice A, destruction of alveolar sacs with loss of elasticity of the alveolar wall. Now, all of these represent a different condition and different presentation, but really, which is going to explain this the best? The young woman, 2-pack year smoking history, presenting with this chronic cough that keeps coming off and on for the past 6 months, with intercostal retractions, nasal flaring, and expiratory wheezing. Take your time. I see a couple people already putting the diagnosis in the question bank. So why don't you guys go ahead and pick the answer that fits this situation the best.
Okay, everybody, we've got the poll launched. Go ahead and let us know what you think the most likely explanation is for this young woman's array of symptoms. And we'll share the results. What do we got here? Ooh, wow, look at this. 60% of you went with answer choice E, reversible airway obstruction secondary to bronchial hyperreactivity. And sorry that one also got cut off, but you guys are all about the bronchial hype. Nice work. Destruction of alveolar sacs and loss of elasticity of the alveolar wall, and then reduced ciliary clearance by the respiratory epithelium came in third. Okay, well, there's a lot on the line here, because if 80% of you went with one option and that's wrong, then we'd have a lot of work to do here. But let's see. Let's answer this question. Hide the results and reveal the answer. And it is indeed answer choice E, reversible airway obstruction secondary to bronchial hyperactivity. Well done, everybody. That was pretty impressive. Of course, some of you may have gotten that question right without really feeling fully confident about it. Some of you didn't get it right, though you might have been considering it. So regardless, this is where the learning occurs when I pass it off to Abraham.
Great job, guys. All right, so this one was more of a slam dunk from you guys. I love to see that. This is a very high yield topic, so it is one that is worth getting correct. So, I saw a lot of people put in the question box there what the diagnosis is. This is indeed asthma. Okay, so you say young woman, really nothing else outside of a slight smoking history, and that keeps having this recurrent cough and shortness of breath, intercostal contractions, nasal flarings, and expiratory wheezing. So that's kind of fitting that obstructive pattern. But like I said, remember, COPD is a disease of old people that have a lot of smoking history, unless we're talking about alpha-1 antitrypsin deficiency. That's why option A really doesn't fit, right? Option A is emphysema, that destruction of the alveolar sac, loss of elasticity. That's all emphysema. So we're not getting there. Option E, on the other hand, whenever I hear the term reversible, asthma always comes in, right? What makes it reversible? Well, if I give someone a thing like albuterol, a beta-2 agonist, it's all going to be gone. So just being able to recognize that, hey, this is just a hyperreactivity of the bronchioles, which lead to bronchoconstriction and this cough and shortness of breath picture, that can be reversed by reversing the hyperreactivity, reversing that bronchoconstriction, by giving medications like inhaled corticosteroids and MySabas and LAMAs and LABAs, and remember all those asthma drugs that we talk about at a different time. But those are all reversible agents, whereas COPD is irreversible damage to the lung. Although you can manage the COPD, you're never going to reverse it. And in asthma, if I'm treating asthma well and I do a PFT on somebody, I sometimes can't even tell that they have asthma because I'm reversing it with the treatment. What about the other options? I think I saw destruction was the second option, which again, that's the emphysema picture. That's going to be not what's going on with just a limited smoking history in a young woman. Unlikely in this situation. I think the next one you guys have is the ciliary clearance, right? So what are we thinking there? So the primary ciliary dyskinesia. So those are kind of people that have hearing issues, they'll have reproductive issues, recurrent infections, infertility in males. Those are the kind of presentation you're going to see with those ciliary clearance. Doesn't really fit that picture. There's nothing, they got to give you something else. They got to say, hey, he's been having infections since he was a little kid, multiple infections, or she is infertile, hearing issues, things like that. Those are the clues that they would point you towards that. I think the next one was the intrinsic that you guys had. That's, when I see chloride channels, think cystic fibrosis. So unlikely in this situation, it's someone who's 25. Typically you get diagnosed at an earlier age. You get infants that are failure to thrive, like usually around age 10 is going to be kind of later numbers. You're going to see them developing. They're going to have GI symptoms. It's a multi-organ issue, not just the lung leading to wheezing. So that wouldn't fit that situation. And then the last one, inflamed bronchi with neutrophils, that would be an acute bronchitis situation. So self-limited, should get better on its own. If they just have that 4 days situation, maybe you can kind of argue that, but it's been going on off and on for 6 months, and it wouldn't really fit that wheezing kind of nasal flaring picture. You would just get more of cough with inflammation, cough, sputum production, things like that. So unlikely in this situation, but good job, guys. This is a classic asthma question.
Okay, very good. Again, lots to learn here, and lots of things, for you to be kind of thinking about as you go through these questions. And while you guys really crushed this one, you're still picking up pearls as we go, even getting those answers right. Okay, so we are getting closer to the top of the hour. I know this has been a fun night. We've had some good questions and some better explanations from Abraham, but this is the final question of the night. So hopefully we can close really strong. And in this case, no images or radiographic findings here, but we do have some other types of findings here. So what we're going to do, obviously, we've covered up the answer choices. So let's read the lead-in. Which of the following mechanisms is most likely behind this patient's catheterization findings? Okay, so by reading that, now you already know something about what's happening with this patient, and the type of question that you're gathering info for. So again, this is perhaps not your typical step one question, right? So again, it's all about the framing, right? It's all about just trying to get your mind, pointed in the right direction as you start, taking in the information here from the vignette, which is what we're going to do right now. A 42-year-old woman comes to the clinic because of difficulty breathing. She has become progressively shorter of breath over the past few months. She has a history of limited systemic sclerosis, for which she takes calcium channel blockers for her long-standing Raynaud and a proton pump inhibitor for esophageal dysmotility. A right heart catheterization is performed with the following findings. Okay, so I'm going to let you just look them over here. You can see the findings for the right atrium, the right ventricle, pulmonary artery, and the pulmonary capillary wedge pressure. Okay, so look over that, and again, we'll pose the question: which of the following mechanisms is most likely behind this patient's catheterization findings? Give you something to try to take this in as I pass it over to Abraham.
All right, so this is definitely a level up of a question. As you can see, we're dealing with some pressures. We're dealing with different parts of the heart, different heart catheterization. What's the difference between a right heart catheterization, a left heart catheterization? These are things that you kind of learn as you go through medicine. You kind of get the clinical exposure. But let's go through. Let's kind of figure out what's going on. Let's figure out the clinical picture of the patient, and you see a lot of highlights. It just means that there's a lot of important information that kind of fits to the patient that would help us get to the answer. Now, I don't want you to overwhelm and jump and get really confused by looking at certain numbers. Let's just take it step by step. So the question is asking, what is the mechanism behind the patient's catheterization findings? Okay, so this patient is having a right heart catheterization, and you got these pressures, and what is that mechanism behind it? Let's look at this. Let's look at the vignette now. You got a 42-year-old woman, okay, young woman, middle-aged young woman, to having difficulty breathing, okay. Progressively shorter of the past few months. So it's chronic. Few months is important to understand. Has a history of limited systemic sclerosis. That's a very important point right there. So limited systemic sclerosis, right? What does that mean? What is the other name for that syndrome? That's a good hint that I'm giving you guys, and kind of take that into account. She's on a calcium channel blocker, and she's taking that for her Raynaud's, and a PPI that she's taking for her esophageal dysmotility, right? And she has a right heart catheterization, and you end up with these findings, right? So what the findings really show: the right atrium is increased pressure, right ventricle has increased pressure, the pulmonary artery has increased pressure, but the pulmonary capillary wedge pressure is normal. It's less than 12. So that's important, right? So what does the pulmonary capillary wedge pressure indicate? Why is that normal, and why is everything else elevated? What is the patient's history of limited systemic sclerosis have to do with all of this? What is the presentation, and what's the mechanism behind the patient's catheterization findings? Now, this is very high yield, very important to kind of understand, and I see some people already dropping the final diagnosis in the question box, so this is important Take your time, really see the big picture here. Don't get caught with the little details. Focus on the clinical presentation and then the patient presenting with all these pressures that are very high yield. So let's go through, let's pull the options up. Again, it's a mechanism question, so they're going to kind of describe different things of what's going on. So you just don't want to fall for the traps. I'm going to go through these, take your time, think about what makes the most sense in this clinical situation. Option choice E, mutation in the BMPR2 gene. Option choice D, increased left ventricular and left atrial pressures. Option choice C, hypoxemia due to alveolar destruction. Option choice B, chronic occlusions of pulmonary arterioles by thromboemboli. And option choice A, arterial destruction and fibrotic narrowing. Now, this is tricky, but there are kind of a good hints that are going on in this question. There are a few good hints, and a lot of you guys are dropping the correct diagnosis in the question box, which I love to see that. But what is causing that diagnosis? What is the connection, and how does that present? So take your time as we pull up the options here. Remember, the right atrium, right ventricle, and pulmonary artery have increased pressure. The pulmonary capillary wedge pressure is normal. And you have somebody with a history of limited systemic sclerosis in a young woman.
Okay, I'm closing it, and let's share the results. So let's see, where are we at? Half of you went with answer choice A, arterial destruction and fibrotic narrowing. The conclusion of pulmonary arterioles by thromboemboli, that came in second. Mutation in the BMPR2 gene right after that. And increased left ventricle and left atrial pressures also scored double digits. But again, pretty strong consensus on this one. So let's hide the results and share the answer. And you guys did it again. Answer choice A, arterial destruction and fibrotic narrowing. Great job. That we gave you some some tricky ones to work through here tonight, but you guys fared really well. Again, if you didn't get this one right, or if you didn't get any of them right tonight, that's great. That doesn't, the main thing is you are, a lot better off, at this point than you were an hour ago. You've been learning. So if you swept it tonight, or just nailed 3 out of 4, you're getting a lot out of it. And Abraham is here to walk us through this one.
All right, so great job, guys. Again, a tricky one here, but I hope that we got enough clues from the question to really get to the answer and the diagnosis. I did see a lot of you guys did say pulmonary arterial hypertension in the question bank, which is exactly what's going on here. So really what we need to understand is this patient has what's called limited systemic sclerosis, also known as CREST syndrome, right? So that's the CREST syndrome, that's where the esophageal dysmotility comes in, that's where that Raynaud's phenomenon and that systemic sclerosis picture that they're painting here. Now they develop pulmonary arterial hypertension. Now, pulmonary arterial hypertension can be caused by a multitude of things. There's actually 5 types of pulmonary arterial hypertension. There's more, we group them in 5 types, and step 1 doesn't necessarily need you to know every single thing about that, but if you do know it, it's a big step, a big help for your step 2 and step 3, because they expect you to know things like that at a higher level. So different types of pulmonary hypertension is important to know. And then within the types of hypertension, pulmonary hypertension, you want to think about what is the situation. So in the options here, they're giving you the different types. For example, option choice E is that BMPR gene mutation. That's the primary cause of pulmonary hypertension. In this situation, this pulmonary hypertension is secondary to the systemic sclerosis, causing fibrosis and causing arterial destruction and narrowing of it, which is what's going on here. If I look at the full picture here, the right heart catheterization is giving you big clues. So the right atrium has high pressure, right ventricle has high pressure, and the pulmonary artery has high pressure. So everything on the right side has high pressure. So that means that the problem is the lungs, right? The lung where the right heart pumps into has high pressure. So pulmonary hypertension. Whereas the pulmonary capillary wedge pressure is indicative of the left atrial pressure. And the left pressure is normal. So really, it's not a problem with the left side of the heart, it's a problem with the right side of the heart. So That would really help me understand what's going on. So option choice D would go out of the picture. As soon as I see that normal pulmonary capillary wedge pressure, that takes D out of the picture. I know it's secondary to something, that takes E out of the picture. E is when we can't find another explanation. There's some gene mutation. It's not an autoimmune phenomenon. What about option choice C? So this is something like emphysema or COPD that leads to chronic hypoxemia, and my lungs vasoconstrict to compensate for the hypoxemia. There's a concept called hypoxic vasoconstriction I want you guys to look into. Very high yield. This question is not the one that's testing that, but you need to know that concept as well. Hypoxic vasoconstriction, which then leads to pulmonary hypertension from things like COPD, things like emphysema, chronic bronchitis. Option choice B, chronic occlusion with multiple microemboli. So having PEs essentially, multiple small PEs can also lead to pulmonary hypertension, which makes sense. You're blocking the way that the right heart pumps into, and that can lead to pulmonary hypertension. But in this situation, really the picture that they're painting here with the history of systemic sclerosis or limited systemic sclerosis in combination with that pulmonary hypertension that they're showing with the right heart catheterization is due to arterial destruction and fibrotic narrows. Good job, guys. If you guys, have more questions about this, make sure you read about hypoxic vasoconstriction and pulmonary arterial hypertension.
Okay, everybody. Again, great work. Thank you, Abraham, for helping us curate these questions and make sense of them. Like I said, so much to learn, but there's also so much to you can take away from each of these questions. And we always think about it in terms of, hey, going through all of the answer choices and the answer options, all those rationales, it's very helpful because you can look at all of these questions and just think to yourself, well, in what case would answer choice be the correct one, right? Or, how would you adjust this question so that it would be increased left ventricle and left atrial pressures? So again, really kind of multiple, not infinite combinations, but all kinds of combinations that are available to you as you're going through QMAX or your question banks as you're studying. Okay, well, let me just note that in the chat I put a link to tonight's QMAX test. So you can go in there or you could screenshot this and check it out later. Again, within QMAX, you'll see all of the rationales, all of the the high yield summaries, as well as connections to RX bricks and flash facts and express videos. We really make it a point to provide you with as much as we can in terms of helping you understand, what's happening in that question, especially for harder questions. And you're like, gosh, I don't know what I got wrong, or I don't quite know what happened. Our team is, that's our focus, making sure that, you're set to get it right the next time, and that we're reinforcing the knowledge that will help you not only with that question but that type of question.